and she's going to speak to us on intraarterial chemotherapy. Where do we stand in 2022? Discussant is Dr. Mahesh Shanmugam from Shankaraya Hospital, Bangalore.
Can you see my slides?
Yes.
Okay. So I've no financial disclosures relative to this topic. I'd like to talk to you on progress with intraarterial chemotherapy, the Philadelphia experience. So it's all about kids and life and vision. There are different ways to manage retinoblastoma, as all of us know, including enucleation and methods of chemotherapy: intravenous, intraarterial, intravitreal, intraaqueous, and even plaque radiotherapy. But most of us around the world now use chemotherapy. The classification of retinoblastoma that we use in Philadelphia is the international classification, groups A, B, C, D, and E, where A is small tumors, 3 millimeters or less. B is bigger tumors greater than 3 millimeters, or those in the macula or with subretinal fluid. C with contained or localized seeds. D with diffuse seeds. And E extensive, greater than 50% of the globe, with neovascularization of the iris and possible opaque media. This classification was established in 2003 with communication of Lynn Murphy and me through emails and over the telephone, and then established in Paris. However, since then, other classifications have come out. So we still use this one that we decided on. What about intraarterial chemotherapy? We tend to use this as a primary therapy for children with unilateral retinoblastoma. We give it through the femoral artery in most cases, but for children over the age of 5 or 6 years, we're now giving it through the radial artery, which is a little bit safer. So years ago, Lauren Dalvin, when she was a fellow with us, published our early experience on primary intraarterial chemotherapy in the intravitreal chemotherapy era. And we found that IAC is effective for groups B, C, D, and even some E eyes. And intravitreal chemotherapy is important, especially to achieve globe salvage for groups D and E. So that's when we tend to use the intravitreal. We did a head-to-head comparison and published in the Asia Pacific Journal of Ophthalmology of intravenous versus intraarterial chemotherapy for unilateral retinoblastoma. In this analysis, we found for unilateral RB, IAC provided significantly superior globe salvage compared to intravenous chemotherapy for group D eyes. And in addition, IAC provided superior control of the solid tumor, the subretinal seeds, and the vitreous seeds. So if we look at this graph, groups A, B, C, D, E, we see the yellow columns represent intravenous chemotherapy with pretty good results for B, C, and intermediate result for group D in globe salvage. But when you compare that to IAC for unilateral retinoblastoma, at least in that publication, we had 100% control for B and C and about 90% control for group D, and that was significantly better than intravenous chemotherapy. And if we look at the components of tumor, looking at solid tumor, subretinal seeds, and vitreous seeds, you can see intravenous chemotherapy does offer some control for subretinal and vitreous seeds, but it's much better with intraarterial chemotherapy. 75 to 90% of vitreous and or subretinal seeds are controlled just with the intraarterial chemotherapy alone, without even injecting intravitreous chemotherapy. And of course, solid tumor is significantly better controlled with IAC. You can see same with the subretinal seeds, significantly better, and same with the vitreous seeds. So when you compare unilateral retinoblastoma, who does better, IAC or IVC? We think IAC wins. It's much more robust, and this is why we choose IAC for unilateral retinoblastoma. And this is important because most unilateral retinoblastoma is advanced. It's group D or E in 75% of cases. So let's look at a few cases here. This is a child we saw who had a macular retinoblastoma exophytic group D with subretinal fluid nasally. And this child received 2 doses of IAC melphalan with beautiful regression, leaving the scar in the macula, but all disease under control. And here's another endophytic retinoblastoma, mostly located nasally. And when you look at the fundus retcam photo, you can't even see the retina. There was a little bit of normal retina superotemporally. After 3 doses of IAC, 6 doses of intravitreal chemotherapy, we now have a macula, a normal nerve, a regressed tumor, and the OCT is intact. This eye saw 20/40. This kid is maybe 8-9 years follow-up and has had no recurrence with following intraarterial chemotherapy. Now, Dr. Ferouz, who's on this seminar, along with Dr. Santosh and our team, published an article in the Indian Journal of Ophthalmology where we indicated IAC is a total paradigm change in how we manage retinoblastoma. And in this article, Dr. Ferouz indicated all the different ways that we can deliver IAC, using it as a primary treatment or a secondary treatment. We do use it as a secondary treatment after failure of intravenous chemotherapy, and even as a tertiary treatment. If it fails again, we'll go back to IAC. We don't use it for tandem treatment in Philadelphia. We do what's called staggered, not tandem IAC. We stagger IAC right eye, then 20 days later, we'll do IAC left eye, because we don't want to have any catastrophic events doing tandem IAC. And yes, we do bridge IAC where we give intravenous in super young kids and then go on to IAC. Here are some special considerations with IAC. We'll begin with minimal exposure. How little can we get away with? Well, there are some kids that we only have given 2 doses, melphalan intermediate 5 milligram dose, and we only give it for 2 cycles. On the top, ABC was one case, and on the bottom, DEF was the second case that got by with just 2 doses, and we have many more. How about the youngest and the oldest? We tend to limit this by the patient's weight, and we generally treat 3 months or older with IAC. But there have been a few 2-month-old children, infants, that we've treated with IAC. This is the little guy who we treated from Chicago, unilateral retinoblastoma. He responded to 2 cycles of 5 milligrams of melphalan and required nothing else thereafter. And the oldest patient that we treated was a 32-year-old man, came from Texas. He's the oldest one that we've treated, but we've treated several 20-year-olds now with IAC. He had recurrence of this tumor in his left eye, and IAC shrunk it down nicely. I have to admit, he did require intravitreal chemotherapy also. Here's a 13-year-old girl. She had endophytic retinoblastoma seen clinically and on the ultrasound. She was the first that we were able to do transradial access. This is safer because if you get hemorrhage, it's not going to go in the retroperitoneal space. And that's what the interventional neuroradiologists worry about. In this case, we went through her radial artery and gave IAC with good results. And we tend to use that for older kids where the radial artery is a little bit larger. And then we've published our publication of 14 years experience with IAC for retinoblastoma in the Journal of the American Association of Pediatric Ophthalmology and Strabismus last year, where we looked at 341 consecutive eyes, 1292 infusions, and looking at a comparative analysis based on patient age, race, and sex. Who does better? Here's an example of a massive group E that we were able to save the eye with IAC. This child is 3 to 4 years out with complete control. So in that analysis, we did Kaplan-Meier graphs looking at globe salvage. So if you look at this graph at 5 years follow-up, Group B, we have 100% globe salvage. Of course, we don't do IAC for Group A. For Group C, we have 80% salvage. Group D, 78% salvage. And Group E, note that this is selective Group E. We don't choose every Group E for treatment. We're able to save over half the eyes. And when we look at primary IAC for retinoblastoma, our 5-year overall globe salvage was 76%, with a mean of 3 infusions, but we go up to 8 infusions. And if a child doesn't respond and we've given 8 infusions, we tend to move on to likely enucleation. Complications are pretty low, only 1% per infusion. Now, if we look at the outcomes based on patient age, less than 1 year versus greater than 1 year, you're going to see control of solid tumor is a little bit better in those under 1 year of age. And control of subretinal seeds doesn't matter based on age, but control of vitreous seeds, a tiny bit better in the younger cohort under 1 year of age, but control of globe salvage, significantly better in young children under 12 months of age compared to older children. And comparison by race and sex, no difference. So what about complications of IAC? When we first started, we had really bad complications. It's a difficult technique and there is a steep learning curve. But as time went on, our complication rate decreased. So if we look at a comparison of primary versus secondary IAC, there was no difference in complications of retinal ischemia, choroidal ischemia, neovascularization, or any of the complications based on primary versus secondary. And looking at age, no difference, race, no difference, and sex, no difference in complications. So in conclusion, for that large database, our results suggest that IAC provides substantial tumor control for advanced and or recurrent with a high rate of globe salvage and few complications. So in summary, it works for retinoblastoma. We tend to prefer to use it for unilateral RB or for eyes that fail intravenous chemotherapy. Thank you for allowing me to give this talk from our retinoblastoma team. And
Mahesh and Mugam will discuss.
Mhm.
Thank you, Dr. Shields. It's, as usual, a great pleasure listening to you and learning from you. Can I share my screen?
Yeah, please.
Yeah, sure. Thank you once again, Dr. Shields, for a wonderful lecture and for continuing to inspire and educate us. So Dr. Shields has showed us that like IAC works, and it's probably the preferred treatment in the developed world as far as the unilateral retinoblastoma is concerned. So what about us? Have we, all of us in India would like to switch over to IAC if it is possible. So let's look at the Indian context as to where we stand. And I had written a commentary on Dr. Shields' article in 2019. So the concerns we raised were this. So the intravenous chemotherapy, as far as India is concerned, we can do it for free. We can do it to patients who cannot afford it. We can do intravenous chemotherapy for free. Otherwise, it used to cost around 5,000 per cycle versus the intraarterial chemotherapy, which costs around 50,000 to 100,000 per cycle. And the stumbling blocks which were there and which I thought could be overcome were by indigenous development of the catheter, because catheter is one of the most expensive parts as far as IAC is concerned in India, and increasing the number of centers performing the treatment. In 2019, most of the IAC was being done in corporate hospitals versus the non-profit organizations or government hospitals. I thought if in case non-profit organizations and government hospitals got into the act, then the cost of IAC may come down. And if there was any governmental intervention in rationalizing the cost. 3 years later, where are we today? So I just did a small survey of 5 or 6 centers across the country which treat the largest number of retinoblastoma patients, including us. And we have found that currently only around 10% of the patients in India are being treated with IAC. So the range is between 5 to 30%. and around 90% of the patients we still treat with intravenous chemotherapy. So why is it? Again, cost is a consideration. So the cost has come down. So in a government hospital, we can do IAC for around 25,000 per cycle, but most often the cost is around 100,000 to 150,000 in contrast to IVC, which is around 5,000 to 10,000. So if you look at the total cost, 3 cycles of IAC would cost about 300,000. In contrast, 6 cycles of intravenous chemotherapy will cost us 30,000. So IVC is nearly 10 times less expensive as compared to IAC. So that brings us to the important question of ability to treat patients who are in the lower socioeconomic group or who cannot afford their treatment. So can we offer IAC as a free treatment to these patients in the lower socioeconomic group who cannot afford them? Yes, but this is on a case-to-case basis. So the treating organization, treating hospital, if it's a non-governmental hospital, then it absorbs the cost. Otherwise, we reach out to a funding agency which is able to afford, which is able to give us the treatment cost. And in contrast, the intravenous chemotherapy is being done in most of the government hospitals and non-governmental hospitals as well. So it is possible to treat them for free, or we are able to absorb the cost much easier. And again, the government scheme, what is called the Ayushman Bharat insurance scheme, which covers the large population of this lower socioeconomic group, the intravenous chemotherapy is covered under that. It's not specific for retinoblastoma. Any chemotherapy is covered. And so intravenous chemotherapy is covered under the insurance scheme, which covers the lower socioeconomic group, which does not happen in the intraarterial chemotherapy. So we have made some progress in the last 3 years. So there has been an indigenous development of the catheter, but unfortunately, it's hardly much different from the cost of an imported catheter. And there has been an increase in the number of institutions performing intraarterial chemotherapy. Particularly in Bangalore, we have 2 government institutions which do perform intraarterial chemotherapy, similar in Delhi as well as in Chandigarh, I presume. And there are non-governmental organizations which do perform intraarterial chemotherapy in contrast to only corporates earlier. So corporates, we had no control over the costs, but then now there is some control over the costs, and people can afford IAC a little bit better than what it was 3 years back. So can the government rationalize costs? Yes, as I mentioned, IVC is covered under the insurance scheme. IAC may be in the future, but then to summarize, IAC is preferred treatment in unilateral RB as shown very elegantly by Dr. Carol Sheets. Though in India, we would like to adopt to IAC, but then cost constraints still remain a stumbling block. We have made some progress in the last few years. We can try lobbying for including IAC in Ayushman Bharat or the insurance scheme, but then RB is a very minuscule health issue in India compared to all other larger issues. So I'm not too sure if we will be able to lobby adequately for the government to include a particularly expensive treatment for a very small percentage of the population. Future, yes, there will be a slow increase in IAC penetration, but I don't know if we'll be able to do as frequently as what it is in the developed world. IVC is still a great treatment, but probably a little poorer cousin. And thank you very much. And I thank the other collaborators who did give me their data very much easily for me to put up this presentation. And thank you very much. Thanks once again, Dr. Shields.
Yeah, thank you, Dr. Shanmugam. That's really multiple important points that you bring up. We've had some very impressive forward strides in the management of retinoblastoma during my career. Number 1, intravenous chemotherapy. Number 2, intraarterial chemotherapy. And number 3, intravitreous chemotherapy. But of these 3 major developments, I agree with you. Intravenous chemotherapy was the biggest step that we took and is still the best, I think, most successful development in the management of retinoblastoma, just because it can be used in every country. So my hope would be that, the cost for intraarterial chemotherapy will come down and be more affordable, especially in your country. I know in the country of Chile, they wrote an article in one of the American journals about the cost of IAC in Chile, in South America, and they were able to get the cost down to $5,000 US, which is, amazing just through using certain techniques. And that was written by Diego Asandon. And, you know, I have hope that it will be more affordable in the future. But I'll be the first to agree with you that intravenous chemotherapy is still a great treatment, and especially for bilateral cases. Yeah. Any other questions?